Hello everyone, welcome to the breakout session for those of you that may have CMT other than caused by sort of what we call the big four, CMT 1A, 1B, CMT 2A, and CMT 1X. So I'm going to go over some generals of other types of CMT, some basics of peripheral neuropathy, and then a bit about where research is going. So just a bit about me. I'm Brett McCray. I'm an assistant professor at Johns Hopkins. So I co-direct the CMT clinic there, and I'm also very interested in TRPV4 neuropathies, that is mutations in TRPV4 that cause various forms of neuropathy. So I study CMT in the lab, and I also see patients in the clinic. So first, just a bit of basics about what peripheral neuropathy is. So if we think about the nervous system, there's the central nervous system, which is composed of the brain and spinal cord. That's where sort of the nerves that control your muscles originate, and then where the nerves that sense things in your body terminate. And so peripheral neuropathy is really a general term for processes that affect the nervous system beyond the central nervous system. So the peripheral nervous system, meaning the sensory nerves after they left the spinal cord, or the motor nerves after they've left the spinal cord. So peripheral neuropathy can affect just the sensory nerves. In that case, it can cause numbness or loss of sensation. It can also cause sort of extra unusual or uncomfortable sensations like tingling or pain or electrical shocks or feeling of cold or hot when those true sensations are not really there. It can also affect motor nerves, and in that case, it generally leads to weakness and atrophy or shrinking of the muscles where those motor nerves are supposed to be targeted. So for the most part, peripheral neuropathy follows a pretty typical pattern. And so it's symmetrical, meaning that it affects both sides of the body, both limbs, both legs, both hands, symmetrically and equally. And the other thing that peripheral neuropathy usually does is cause what we call length-dependent symptoms and length-dependent disease, meaning that the severity and the kind of distribution of symptoms happens in the longest nerves first. So the longest nerves are those that go from the lower spinal cord down into the toes, and those are longer than the ones that, say, go to the thighs or go to the fingers. And so what generally happens with peripheral neuropathy is that symptoms usually begin in the toes and in the feet. And over time, if they progress, they affect sort of shorter and shorter nerves. So then they move up into the symptoms can move up into the shins and then up into the knees. And over time, as things progress up the legs, you start to get symptoms in the hands, because those nerves that go into the hands are about as long as the nerves that go to the knees. So this is what we call a length-dependent distribution. Sometimes it's also called a stocking and glove distribution, as you can see here, basically by the distribution of symptoms. So some basics of what nerves actually are. So they're sort of can be thought of as electrical wires that conduct electrical signals, which either move muscles or transmit sensory information from the body. And so in this analogy, the wire is the axon of the nerve, and then the insulation around the nerve, around the wire, is the myelin sheath. And the myelin is sort of wrapped around in these discontinuous segments here. And so peripheral neuropathy can affect either the underlying wire or the axon, or it can affect the myelin sheath, or it can affect both. So a demyelinating neuropathy is one where the myelin is the primary target of the disease process. This causes slowing of nerve impulses, which we can detect by EMG. And then in an axonal neuropathy, the problem is really the underlying axon, and usually that happens at the end of the axon first and slowly works its way back. But the myelin closer to the cell body is actually intact. So in this case, the speed of nerve conduction is normal, but the actual size of the signal that's transmitted by the nerve starts to get reduced as some of these axons start to degenerate. So to go into a bit about types and classifications for inherited neuropathy, it should be noted that unfortunately the naming of inherited neuropathy is a bit of a mess, and so this has been something that's evolving over years. And so if it's confusing to patients, it's because it's sometimes quite confusing to the physicians as well. And so what was originally described as what we would call sensory and motor neuropathy, meaning a neuropathy that has both a sensation component and a strength and muscle component. These were described by these three physicians, Charcot on the left, Marie in the middle, and Tooth on the right. So it's two French physicians and one English physician. And so they basically grouped a lot of what looked like inherited neuropathies together under this umbrella term of Charcot-Marie-Tooth disease. And they divided it up into type 1, which is demyelinating neuropathy, where the myelin is the primary problem, and type 2, axonal neuropathy. But there are also variants of inherited neuropathy that affect only sensation, and those are generally referred to as hereditary sensory and autonomic neuropathy, or HSAN. And then there's varieties that only affect motor nerves, so those are generally called hereditary motor neuropathy, HMN. But in a lot of cases, there's significant overlap. So sometimes someone may be diagnosed with an HMN, but over time, sensory symptoms may emerge. It's also the case that some genes that cause HSAN or HMN or CMT can cause one or the other. So it seems that whether it's sensory and motor, or motor only, really depends on the patient, not so much on the underlying genetics. So it's complicated. So I think most of us who see CMT quite a bit now will sort of call anything within this spectrum CMT. So we may refer to HMN as a type of CMT. And so there have been a lot of different forms of CMT that have been defined over the years. And this is just a partial depiction of some of those. And you can see this sort of overlap between CMT1 and 2, HMN and HSN. So these distinctions, as I was saying, are not 100% distinct. There's a lot of blurring of the edges. And inherited neuropathy can also be associated with other problems in the body. So CMT is generally reserved for conditions where neuropathy is essentially the only manifestation, but sometimes there are other kind of multi-organ or multi-system conditions that also cause neuropathy. And so one of them, giant axonal neuropathy, has a really prominent and severe neuropathy, but there's also manifestations in skin and hair, in the heart, and other tissues. And then an important form of neuropathy, familial amyloid polyneuropathy, also sometimes called TTR neuropathy or hereditary amyloidosis. This is a pretty often aggressive and severe neuropathy, but also has associated heart problems. And as I'll talk about later, this is one for which a treatment was recently developed. So some of you may already have a genetic diagnosis of a type of CMT. Some of you may be suspected of having CMT. Some of you may not know for sure. So I kind of wanted to go through a bit of how we as physicians think about whether someone might or might not have an inherited or genetic neuropathy. And so none of these rules are hard and fast 100% of the time, but in general, people with inherited neuropathy tend to have more loss of sensation, more numbness rather than tingling or pain. It's often the case that when we do an exam, we may find more kind of loss of sensation than you might be aware of. We also tend to see weakness in the toes, feet, and ankles first. Changes in the way the feet look are quite common with inherited neuropathy. So there's what we call high arches or pes cavus. Sometimes they're flattened arches, and sometimes these hammer toe changes, these curling of the toes, can be quite suggestive of an inherited neuropathy, particularly if they happen early in life. These can happen for other reasons as well, so having changes in the way your feet look does not necessarily mean that it's an inherited neuropathy. Often because of the atrophy of muscles, particularly below the knees, the legs can appear very skinny, and then weakness and sensory loss in the legs can manifest with difficulty with running, jumping, or difficulties with balance. Because of the length-dependent nature of CMT, usually symptoms in the hands occur later in life, but unfortunately they often do occur in many types of CMT. And then one of the telltale signs of an inherited neuropathy is that other people in the family have it or have had it. That's not always the case, but that certainly makes us think that an inherited neuropathy is more likely. So there are different ways that neuropathy can be inherited in families. So the most common is what we call dominant disease, meaning that for all of the genes in your body except for the sex chromosomes X and Y, all the other chromosomes, you have 2 copies of each gene. And so for a dominant disease, you only need to have a disease-causing change in one of the genes, and so the other gene is normal. And so you would essentially get one of those from a parent, a carrier for the disease gene, and then you would get one normal gene from the other parent. And that's, like I said, most commonly the case with CMT. There are also recessive forms of CMT, meaning that you only get the disease if you get an abnormal disease copy from one from each parent. So you need to get 2 copies of the disease gene. And just as you could imagine, just by chance, that's less likely to happen than a dominant disease. And then there's also some that are X-linked, meaning that they travel on the X chromosome. So these, in this case, whether you're male or female, has a large influence on whether you're likely to have any manifestations of the condition and how severe those are. So with an X-linked disease, so CMT1X is the most common one that we think of, males are more affected. Sometimes females can be asymptomatic or have only mild symptoms, but they can pass it on to their children, both males and females, and then males can only pass it to daughters. And then there's other situations where the genetic change can arise with no family history. It can just sort of show up in someone, and we call this a de novo mutation, meaning that it just kind of came on spontaneously. So in that case, obviously, there's no family history to guide the genetic diagnosis. So when we evaluate a patient as a physician and try to decide whether they likely have an inherited neuropathy or not, these are some of the things that we look for. So certainly, as I mentioned, a family history. The most useful are first-degree relatives, so that's parents, siblings, or children. Age of onset is another key factor. So in most forms of CMT, symptom onset is before the age 40, and usually some sign of the condition manifests in the teens or 20s or even earlier. And then maybe once symptoms become more prominent later in life, even looking back, there's often some subtle hints about the possibility. So there may be changes in the way the feet look that have been present throughout life. There may be a history of maybe not being the fastest, not being the most coordinated as a child, not being great at athletics, maybe being picked last for team sports, frequently kind of rolling the ankles and falling and being a bit clumsy. Those things are all kind of suggestive. But we do know now, certainly as we've learned more about genetics in CMT, is that there are late onset forms, and we define that as after the age of 40. And so some types of CMT tend to be more late onset, and then even genes that can sometimes cause early onset in certain people for unclear reasons can also cause late onset. And so you can imagine if someone is from a family where multiple family members have been affected, they have early onset disease, you're very confident that they have CMT. Whereas if someone develops symptoms later in life and there's no family history, maybe there was a de novo mutation, they're the first ones, it's much harder to be certain of that diagnosis. So on exam, we particularly look for the things I was pointing out earlier, changes in the muscles, particularly in the lower legs, and then problems with sensation, problems with balance, and then changes in the way the feet look. And in some cases, but not all cases, the EMG can be really helpful in suggesting a inherited neuropathy. In particular, with CMT1A, there are really hallmark findings on EMG. With type 2 axonal CMTs, there's generally not any features that really jump out and point to an inherited neuropathy, other than sometimes the EMG, the numbers will sometimes look worse than the patient, meaning that we might not be able to find any responses in many different nerves, but clearly those nerves are still working to some extent when we do an exam. So that disconnect can sometimes be suggestive of an inherited neuropathy. So things that argue against an inherited neuropathy, again, these are not 100%, but in general, these tend to be true. So if symptoms come on rapidly, that usually suggests something that has acquired in life rather than genetic. If there's a known reason that you might have neuropathy, like severe diabetes or other kind of vitamin deficiencies, that would push you away from a genetic neuropathy diagnosis. There's a lot of asymmetry, so one hand, one leg, much worse than the other side, that usually suggests something non-genetic. And then some people can have really severe symptoms in the legs, weakness, numbness, but sometimes that can be coming from back problems, pinching of nerves in the back or spine. And then if we do an EMG and we see certain patterns, what we call non-uniform changes, meaning kind of patchy changes, that can be more suggestive of something that was acquired in life, maybe autoimmune rather than an inherited process. So to get back to the types of CMTs, I think I mentioned earlier, there's now over 100 different genes that have been identified to date that cause different kinds of CMT. So this is a partial list. So on the top is dominant forms of CMT, and on the bottom is recessive forms, and they're kind of broken down into these, pure motor or pure sensory or CMT combination groupings with type 1 and type 2 demyelinating versus axonal. And again, there's a lot of overlap and a lot of kind of messiness to these classifications. But over the past 20, 30 years, there's been a huge increase in the number of genes identified, and we're still always finding more. And even in the past couple of years, some relatively common forms of CMT have been described only recently. So there may still be a big chunk of CMT that we have yet to discover, but it's hard to predict. So to try to make a genetic diagnosis of inherited neuropathy or CMT, we often do genetic testing. And these days, I think most of us who see a lot of CMT rely on these genetic testing panels, most often through a company. Either, I think Invitae is one that I most often use. Some people also use GeneDx, both of which I think are really good companies, and they work with us really well and produce good results and thoughtful results. So on the right here is the current panel from Invitae, which has, I think, 102 different genes. So includes most of those where we're pretty confident that the research shows that these genes can cause disease. And so the big four, as we kind of call them, make up a large proportion of CMT, meaning the most common four genetic diagnoses. CMT1A is about half of all cases. So it's about 40% of all cases where there's CMT, but then some cases there is no answer that's ever found. So if you kind of separate those out, then 60% of those that actually get a genetic diagnosis end up being CMT1A, roughly. And then CMT1X, CMT2A, CMT1B are kind of the next three most common. So much less common than CMT1A, but still more common than all the other types of CMT. So those numbers just refer to the percent. So for CMT1X, 6.5% of all cases and 10% of those with a genetic diagnosis. So then there are these 94 plus other genes that account for the remainder of the whole piece of the pie of CMT, and each one of those is a pretty small chunk of the remaining known forms of CMT. And so this is from the inherited neuropathy patient database, so looking at our own internal percentages. And so if we look at just type 2 CMT, mitofusin 2 mutations, so CMT2A, make up nearly half of all of those cases in the inherited neuropathy consortium database. And then the rest of these genes here, this is only a partial list, but each of them is only 10% or less than 10% of all CMT type 2 within this database, and so there's still 20% undiagnosed in this group. And so of those remaining kind of less common ones, MPZ, TRPV4, GDAP1, and NEFL are the most common among the kind of less common subtypes of CMT. But in general, sort of clinically, phenotypically, based on symptoms and what you experience having one of these forms of CMT, for the most part, the genetic diagnosis doesn't really have that big of an impact on what we expect sort of symptoms to be. So most forms of CMT are more similar to each other than they are different, but there are certainly exceptions to that rule. So there are some forms of CMT that have distinct features. And so this is a couple of really nice images from a recent review highlighting some of these sort of CMT type specific manifestations. So kind of weakness up in the shoulders and in the arms is not typical of most forms of CMT, but it can be seen in certain kinds shown here. And then GI involvement or autonomic problems, so problems with the, having things move through the gastrointestinal tract, things other autonomic things are sweating, urination. Sometimes those can be affected in certain subtypes of CMT. And then vocal cord weakness is something that can be kind of an unusual, somewhat uncommon manifestation of some different forms of CMT. And then eye problems, so visual problems or other ocular involvement can be kind of seen in some specific forms, particularly metafusin 2. So one question that often comes up when we talk to people about whether to do genetic testing and how far to go to try to establish a genetic diagnosis is what do we do with that for information? Why is it useful to even know? And so the best reason would be if there were treatments. And unfortunately, for all forms of classical CMT, right now there are no treatments. I put yet because this is a very active area of research. One that most of us who see CMT are, I think, really interested in, but as of yet, we don't have anything to offer to really stop or halt or reverse the underlying disease. There are forms of inherited neuropathy that are not called CMT. I mentioned one earlier, familial amyloid polyneuropathy, and there's other metabolic neuropathies that some of them do actually have treatments. And so if we find one of those, it's very useful to know, obviously. So I highlight this familial amyloid polyneuropathy really because it's been a landmark achievement in this kind of inherited neuropathy research. So in the past few years, these two papers came out with basically similar but somewhat distinct treatment strategies for this particular disease. Basically, in this condition, there's a protein that gets made that sort of forms aggregates and kind of sticks to nerves and causes damage. And these different treatments reduce the amount of that protein and sort of clear it out of the body. And they have been really effective, and it's a really huge development for these people. So the other thing you can do if it doesn't turn out that you have a treatable form of neuropathy, which is unlikely, is to participate in research to try to help us learn more about neuropathy and eventually develop treatments. The other things that are useful with a diagnosis of inherited neuropathy is that it does have an impact on prognosis. So in general, we kind of know what CMT does over time. It's a bit different in everyone and different in families, but we can give some information on what the disease process will likely look like. And that can also help you to avoid more diagnostic testing and maybe even treatments that have side effects that could be somewhat dangerous that won't help. So the example is there are certain autoimmune neuropathies that can respond to things like steroids and other immunosuppressive medications. But if you know that you have a genetic neuropathy, then you shouldn't try those because we know those are not effective in those cases. And some patients also have different surgeries to try to improve weakness or foot deformities, and often, depending on the circumstance, we can kind of provide input on whether those things are likely to be helpful or not with CMT. And generally, we try to avoid surgery, at least later in life, for any form of CMT. It can also give you some peace of mind, and so you sort of know what you're dealing with, you know what the family is dealing with, and it can kind of help end sort of diagnostic uncertainty. And then certainly knowing a particular gene can help you test other family members and plan and use that information for family planning. So the other big thing with having a genetic diagnosis is participating in research. So right now, what we're doing a lot through the Inherited Neuropathy Consortium and other kind of global efforts is what we call natural history studies. And so this is basically research to define what normally happens with different kinds of CMT. So CMT in general and then specific subtypes. And so this is an image showing over time someone with CMTA changes in the way their foot looks by MRI. And so this is really maybe not the most exciting research to be a part of. It doesn't feel like you may be doing much, but these are really critical studies to be done to foster future clinical trials. So you can only know if a drug works if you know what would happen if you didn't give the drug. So that's where these natural studies really become absolutely critical. But this can be difficult with rare forms of CMT because it's hard to find a lot of people that have a rare form of CMT. It's hard to get enough numbers of people to really be confident of kind of what the normal range is and what the sort of noise is. So then the other things that we are trying to do more and more these days are treatment studies. And so these generally have to rely on animal studies. So either making, basically trying to give CMT to Drosophila, fruit flies, or to mice. And for many reasons, this is the place to start because we can do a lot of different testing in these animal models that we can't do ethically or nor do we want to do on people. And there's also a lot of pretty amazing things we can do to really look in detail at the nervous system in these animals and really understand not only how to treat these conditions, but sort of what's going wrong, and that can have impacts on research in sort of general nerve health well beyond CMT research. So the ideal treatment obviously would be something that would benefit all or many different CMT types. And so that would be what we would like to find. It's pretty hard to find something like that. But what we can do is sort of break down the general strategies that might work in different types of CMT. So as I mentioned before, recessive forms of CMT, you have 2 copies of the disease gene. So these are not as common as the dominant forms, but there's still quite a few patients that do have recessive forms of TMT. And in general, what happens in these diseases is that basically you lose function of the disease gene. So the disease gene, because of those 2 changes in each gene, maybe you don't get any of the gene product. And so you're essentially lacking that particular gene, that gene function. And so a simple thing is to basically add back the disease gene. And so this is where kind of novel gene therapy approaches come in. So I mentioned earlier this condition, giant axonal neuropathy. And so because this is a really severe disease and it's a loss of function recessive disease, basically due to loss of an enzyme, there have been studies in animal models of this disease and now in people using gene therapy, basically a virus to deliver a gene for this giant axonal neuropathy. And those studies are ongoing. So this is really kind of at the leading, pioneering edge of treatment of inherited neuropathy. And so we'll have to stay tuned to see how that goes. But increasingly, these strategies are going to be tested in the appropriate situation. So this could really be revolutionary eventually if these kinds of strategies work for recessive types of CMT. For dominant forms of CMT, there's 1 copy of the disease gene. And so this is, like I said before, the most common type of CMT. And in these cases, there's a gain of function, meaning that the disease gene is now doing something that it's not supposed to do. And so it's a little harder to try to figure out what to do about that. And so what you would ideally do is lessen that disease gene in some way. But it turns out that's not so straightforward as replacing a gene. But there are some strategies, basically these what we call knockdown approaches, to try to eliminate just the disease gene. But to be able to do that and spare the normal gene is not so straightforward, but there are efforts ongoing to do that. So other potential treatments are based on understanding the specifics of a particular CMT type. And so this is probably the type of treatment that would be more relevant to those of you that have some of these less common types of CMT. And so in this case, we make an animal model, and then we give the nerve some kind of disease, essentially chop them up like a sort of like a baguette here, and then look at it under the microscope, and then study whether treatments can make this nerve on the right, which is the disease nerve, look more like the nerve on the left, which is the normal nerve. And so there's a few different studies I wanted to highlight quickly just to show you some of the work that's being done. So in CMT2D, in CMT2C, and also what's called SORD neuropathy. So in CMT2D, the mutations are in this enzyme called GARS, which is a tRNA synthetase. And so there's other tRNA synthetases, MARS, WARS, YARS, many of them. And those also, with certain mutations, also cause forms of inherited neuropathy or CMT. So findings in CMT2D may translate to other related forms of CMT. And so a couple of recent papers showed that if you put this mutant form of GARS into mice, they get sort of diseased nerves. So this is a normal nerve here on the left and a diseased nerve on the right, so it's much smaller. And there's a sort of stress response that happens. If you inhibit that stress response, you can bring this abnormal nerve closer to the normal nerve. They also found that this mutant GARS protein sort of sops up an important other protein. And so what they found is that they can overexpress this other protein. So not the mutant form, but this thing that it's sort of binding up. And so when they do that, they can take, so this is a measure on the right of grip strength, so a kind of measure of motor function. So the sick mice are in the green here. Over time, their grip is much lower than normal mice. But if you give back extra of this thing that's getting sopped up, which is in the purple line here, you can make those mice essentially normal. So this is another strategy by gene therapy where you might be able to fix the problem that comes with these mutations in CMT2D. In TRPV4 neuropathy, which causes CMT2C and related forms of spinal muscular atrophy, the mutations are in this ion channel called TRPV4, and they basically make this channel, which sort of sits on the surface of cells, they make it open more than it should open, and so that lets things flow into the cell that shouldn't normally flow into the cell, or at least shouldn't flow in as much as they do with the mutations. And so in a fly model, we've been able to basically make flies sick by putting in disease forms of TRPV4, and then if we give them a TRPV4 blocking drug, we can rescue those problems with the nerves in basically the fly larvae here. And this is exciting because there are already TRPV4 blocking drugs that have been tested in clinical trials for other indications, and so our hope is that we can someday use these or try these drugs on patients, because we think there's a good likelihood that they would be beneficial. And then the last story I wanted to tell is about SORD neuropathy. So this is a new form of neuropathy that was discovered within the last year or so, but it actually turns out to be probably the most common form of recessive neuropathy. So it had sort of escaped our notice for sort of interesting genetic reasons, but it was recently discovered by Stefan Zuckner's group in Miami. And so this is a mutation in an enzyme that functions in this pathway taking glucose, which is sort of regular sugar, and turning it into a different sugar. But in between that is this intermediate sugar called sorbitol. So if you don't have SORD, which is this enzyme here, you accumulate sorbitol. And so this is shown with blood from people that have SORD mutations. They have elevated sorbitol. And it was already known that sorbitol is toxic to nerves. So this is something that seems to accumulate in people that have diabetic neuropathy. And there are already drugs that are on the market to block production of sorbitol. So they basically block this pathway, this enzyme that before sorbitol, so they can reduce the amount of sorbitol. And so when these were given to a fly model of this disease, the flies got better. And so there's a lot of hope that giving these already approved and safe drugs to people that have SORD mutations may actually provide benefit. So that's really an ongoing area of interest. So those are kind of the main things I wanted to highlight. And with that, we can now move on to questions and discussion. So there we go. So sorry for the technical difficulties with that presentation there, but there's a few questions that came in during the talk, which I can try to start addressing now, maybe. Because there's some in the chat and some in the Q&A. So going back to actually, yeah, Hunter, do you want to sort of field the questions and throw them to me, and I'll try to.
Yeah, of course. And let me know too, what's kind of within your realm of answering, and for other things, we can also, reach out to Eric and stuff as well. Mary Kate had a question about tendon transfers. She was wondering, it seems to be very common for CMT patients for surgery, but recently heard that it's not very recommended, and was just wondering if you had any perspective on that.
Yeah, it's something I mentioned in the talk. So I'm an adult neurologist, so most of my opinion comes from the adult world, which is, I think in general, surgeries are performed more often in pediatric patients that have kind of earlier onset symptoms, and that's a very different situation. But in general, with CMT, because it's progressive and as I was describing, length dependent, usually sort of the muscles, say in the legs or in the hands, if they're affected, usually the nearby muscles are also affected. And so tendon transfers usually take a strong muscle and hook it up to a weak muscle. And so what that ends up doing is helping one muscle but hurting another. And over time, often with CMT, a tendon transfer using a sort of a good muscle will provide short-term benefit, but it'll weaken the other muscle long-term, and then that muscle will maybe eventually also start to develop weakness as the disease progresses. And so it's kind of a short-term stopgap fix that in my experience doesn't help as much long-term. But in children, it's a very different story.
Got it. That's really, really helpful. And Mary Kate, does that answer your question? Yep, perfect. I think that's all set. We had another question surrounding a variant of CMT. I could try to pronounce it, but I'm definitely going to butcher it. It's the CHR19 with a number of other numbers. Do you have any sort of knowledge or information surrounding this you might be able to share?
Right, this was the EGR2, or is that a different one?
This is a new patient with CMTE2, a new variant found in gene PRX.
Oh, PRX. Sorry, new variant. Yeah, so this is generally an X-linked form, I believe. So it means it's generally causes symptoms in males and not females. And my experience also has been that there's a lot of changes in this gene that get picked up on genetic testing that might not be truly pathogenic, but this looks like it's a deletion. So if that's the case in a male, a deletion could certainly cause CMT because this is one form where you lose function of the gene, and that's how you get disease rather than it does something it's not supposed to do. So in a female, losing one copy usually wouldn't be enough to cause disease, but in a male, it probably would. So that's what it's sort of what I was saying. It's challenging. The nomenclature is confusing, and now we're getting so much genetic information so quickly that it's often hard to sort through what's really causing disease and what's not. But in the right person and the right set of symptoms, that particular PRX mutation certainly could be the cause. It's not one of the most common forms, but it's on that, as I was saying, kind of once you get outside of the 4 or 5 most common forms, you're dealing with 1, 2, 3, 4% of all CMT with a lot of these other forms.
Got it. No, that's very helpful. And then a question in another direction. Xin Chen mentioned, since sorbitol is toxic, is it odd to add that to PTX 3003, that trial? Yeah,
that was interesting how those two sorbitol came up twice in the same talk in opposite sides of the coin. So I think in the one case, you're giving sorbitol that probably doesn't. So I think that the crux of it is whether it's inside of a cell or not. If you're giving sorbitol as a medication, it might be doing something very different and sort of in the bloodstream. Whereas in SORD neuropathy, the problem is that the cells are getting filled up with sorbitol. I think that's the main difference. So in the case where the cell is sort of inappropriately making sorbitol or can't break it down, then it becomes toxic as it builds up. Whereas if you take a drug where sorbitol is part of it, it's having an effect outside of the cells. So certainly loading cells with sorbitol would not be a good idea, but taking a pill that has a little bit in it would be very different.
Got it. Okay, that's very helpful. And I'm going to pop over to some of the Q&As that I think you've probably seen as well. But do you mind going into the difference between 2C and 2CC?
2CC, I would have to look into that one. So
okay.
I know there are a couple of different. Usually when there's like if it's 2A, B, or 2AC, usually that means that the way patients look is similar, but there turns out to be more than one gene that causes that same kind of clinical picture. So 2C, for example, can have vocal cord weakness. And we know, I'm aware of at least 2 genes that have the designation of 2C because they cause vocal cord weakness in families, but they're actually different genes. But I'm not sure which. So like maybe there's a 3rd gene that I'm not aware of off the top of my head, but that's probably what it is. Sort of, as I was saying, there's most of the time the different forms of CMT, at least the dominant forms, look pretty similar, but when they have an unusual feature, they might get their own designation of a letter. And then if there's multiple genes that kind of make patients look the same way, they'll get different. So the thing is that a lot of these names were developed before genetics was really had caught up. And so we we sort of classified people based on how they presented, and then we found that that didn't always mean one single gene. It turns out several genes can look the same way.
Mm-hmm. Yep, that makes sense. And Clemens, I can double check with Keith too to see if there's any specific information regarding 2C as well.
Yeah.
That's helpful. And then we have a question regarding CMT2K. Lean is curious to know if your clinic at Johns Hopkins has worked with patients in this subtype.
And sorry, remind me, I think is that GDAP1 mutations, or am I, even those of us who see these all the time, because there's now 100, we still have to look them up. If that's GDAP1, which I'm guessing it is, we have seen some at Johns Hopkins with that condition. That's one of the kind of unusual ones where you can have one copy and you get one type of CMT with one, letter designation, and 2 copies of the disease gene can also happen. And usually the type with 2 copies is more severe than the type with 1 copy.
Great. Yep. And Lean confirmed as well. It is GDAP1. Perfect. We have a question regarding CMT2S. Curious if there's anything going on within this space as far as special developments or any studies that Hans might be interested in looking into.
So again, type 2S, I would have to look up.
Okay.
To be honest, I could try to do that quickly, but I think, one of the maybe take-home messages from this session that I'd like to communicate is that because these are rare, the treatment strategies partly will piggyback on what's happening for the more common ones. So you heard some really exciting work about CMT1, 1A. There's a lot going on with CMT2A as well. And in some cases, that work will be kind of, whatever works in those can be applied to some other rare kinds. In some cases, the rare forms will have kind of a unique challenge that they pose and a unique possibility. And so that's kind of what I wanted to highlight with the 3 cases I showed. But I think it depends on the exact nature of the gene that causes the type, what strategies are available. And then to some extent, it depends on if there's someone, some researcher out there who is interested in that particular gene and is kind of pushing things forward. One good thing is that I think the industry interest and the research interest and the kind of broader interest in CMT is going up. So more people are studying it. The papers that get published on CMT are in higher and higher impact journals. So I mentioned there's 2 science papers just came out in the past month on one form of CMT. So there's more interest, and hopefully that will start to address the need of these rare subtypes and get people, young researchers interested in studying them and trying to figure out how to treat them. But I think there's a lot of movement on these sort of general strategies of gene editing. So that's something that can be applicable to any kind of CMT, or if there's too much of the gene, knocking it down, if there's a lack of gene, replacing it. Those kinds of strategies will eventually, with enough time, be applicable to CMT2S or K or L or whatever the case is. But I think right now, for the most part, the rarer forms, it's a bit of depends, just whether there's someone that happens to be studying it, and probably for most of them, there's not a lab or a group that's really dedicated to that particular gene. Just so many of them right now.
Yeah, that's helpful and that's good to know. And I think a lot of these questions that we have coming through the chat correlate to a specific type of CMT. Are there any resources out there that you would recommend individuals into if they do want to find out more information on a certain subtype?
Let me see. I think of the best. I mean, I think being seen at a CMT center would be the best way to go. So, as I sort of apologize that I don't know details of all of these. I don't think any of the CMT specialists have them all, on the tip of their tongue with the difference, the nuances of different forms. but certainly if I were going to see someone in my clinic, I would read up on them beforehand and familiarize myself with all the details. And I think that's probably the best way to get, really relevant clinical information. I'm not aware of a good resource other than kind of clinical resources that are written for physicians to help. So, if you have a scientific background or can kind of understand the clinical speak, then there's some resources that could be helpful. I think this is also hit or miss. There's a series of websites, sort of papers called gene reviews that is really good. So if you go to gene reviews and type in the particular gene change that you have, often those are written for clinicians, but not necessarily for CMT experts. And so it'll still be sort of written in a clinical way, but it has a lot of, I think, if you're lucky enough that there's an entry on your gene, that there's a lot of good information on that. So it's gene reviews as one word.
Perfect. That's good to know. And if people do have questions, feel free to use the raise hand function, and I can cause it so that you guys can talk and ask the question yourselves. I think Jay Richards had a more specific question. Jay, I'm going to turn on your functionality in case you want to ask it yourself. Jay, do we still have you there? All right, I will oh, gotcha. Okay, Jay does not have a mic, so I will ask the question then. Jay's curious if you think there might be a possible link between TRPV4, CMT2C, and arthrogryposis. I'm not sure if you're familiar with that, but curious on your perspective there.
That's one I am familiar with. Yeah, so that's definitely one of the things. Arthrogryposis can be seen with CMT2C in particular. So that term refers to kind of contractures of the limbs, and that can be caused for many different reasons. But the commonality among the different reasons is if there's reduced movement in utero in the womb, you can get these kinds of the joints can get kind of stuck in place, because to develop joints normally requires the sort of movement around in the womb. And so any genetic condition or other condition that causes reduced movement can cause that kind of problem. But TRPV4 or CMT2C can definitely be associated with it.
Great, that's super helpful. And correct me if I'm pronouncing your name wrong, but Bhuvanaswari, I think you had some questions too, so I can in case you would like to ask your questions live to Brett.
Are you able to hear me?
Yep.
Yep. Sir, we are from India and we are here in the United States for 4 years now. My daughter, when she was 3 years old, we see some gait difference in her legs and small weakness in her hands. Then we get a genetic testing. I shared the genetic testing results in the chats. So the positive homogeneous genes found on the GDAP1 and a few other also we found. The result says, summary, positive result, homogeneous likely pathogenic variant identified in GDAP1. Variants of uncertain significance identified in DST, FIG4 and PLEKHG5. Homogeneous variant of uncertain significance identified in MED25. This is the summary, and the clinical summary I sent in chat. So just I would like to, I did made a lot of research in the Google, and I found myself it's a 4A, but in the some of the presentation, I see GDAP is linked with the 2K also. So I would like to see your opinion. How do you conclude whether it's a CMT4A or some more testing required to conclude that? Just we did only one blood testing with my daughter that gave these results. We have a one more son, 10 years old. He don't have any issues. Actually, we both are first cousins in family. We got married.
Yeah. So based on the genetic, what you read and what you shared earlier, I think it's the 4J type. So because it sounds like there's 2 copies of the GDAP1. So your daughter has 2 copies of GDAP1. If one copy has a disease gene, then it would be the type 2 variety. And if there's both genes have a disease mutation, then it's the type 4 variety. So that would be recessive. And so it's just this is kind of an unusual CMT in that it can cause 2 different types. But since she has, it sounds like 2 different mutations, or the same mutation, but one on each chromosome, then it's the type 4 kind.
Great. Thanks, Brett.
Sure.
Anything else about Bhuvaneshwari that you would like to add? All right, sounds good. It looks like we also have a question from Colin Stoll. Colin, I'm going to enable your microphone in case you would like to ask a question. Colin, are you able to ask the question, or would you like to? All right, I will move forward, and Colin, feel free to jump in if you are able to figure out your microphone. But Colin is curious if there are any case studies using relatively safe novel approaches to treat CMT2C and its side effects, specifically surrounding exercise, diet, sleep, and supplements. If there's been anything that is correlating there.
So I couldn't, you broke up a little on the subtype of CMT, but I think
That was the 2C subtype.
So I think.
Sorry.
Oh.
Microphone problems before. Thanks for it.
Perfect. Colin, you're a little bit quiet. I'm not sure if you're able to get a little bit closer to the microphone.
Can you hear me? Is that better?
That's better, yeah.
Okay. Sorry. Thanks for asking the question. No. Yeah, the main question was, what you said on CMT2C.
Yeah, so for CMT2C or any form of CMT at this point, there's no general kind of safe, simple treatment that we know is effective. So we don't know of any general dietary modifications or supplements that are generally helpful. I mean, we do know that leading a healthy lifestyle is beneficial, and certainly exercise is beneficial. So it used to be the case that people with muscular dystrophy or CMT would be told that if you exercise a lot, you're going to make things worse, and that's definitely not the case. Regular exercise does seem to slow the progression of neuropathy really from any cause, whether it's diabetes or CMT. So exercise is good as long as you don't do something that puts you at risk of falling or getting hurt. We definitely recommend that. And then, a healthy diet to the extent that, you don't have too much sugar and if you have diabetes, that you control the blood sugar is helpful. But beyond that, we haven't found anything that's sort of simple and safe and provides a general protection of nerves.
So the idea is to prevent any sort of secondary inflammatory conditions with the body in terms of diet, exercise, sleep patterns.
Yeah.
As well too, so you don't have the compounding effect.
Right.
Of age-related diseases, which are pretty common in the United States.
Right, and then, being overweight, having high cholesterol, high blood pressure, high blood sugar, all those things are not helpful for nerves in general.
Yeah, exactly.
So those things apply to everyone, but probably more so to someone who has already an inherited nerve condition.
Yeah, and again, really quick, your focus is on calcium channel blockers that are specific for those axons that are affected by the CMT2C.
It's specific for the TRPV4 ion channel, wherever that happens to be, which is something we don't entirely know, and or where it has to be to cause the problems. But
Okay.
that's an example of one of those very specific therapies that really, it's only for that subtype of CMT.
Yeah. But you're still working on that in that pathway.
Yeah, I don't know if there's anyone else who has TRPV4 mutations. I'm doing a breakout session right after this at like 3:15 to talk about that specifically. So if you want to hop in on that.
Okay, perfect. Thank you.
Great. And I think we probably have time for one more question. I saw a question from Mary Kate, I think it was in the chat as well. So Mary Kate, I'm going to turn on your microphone, and if you're able to ask it yourself, that would be
great. Can you hear me?
Mm-hmm.
Yep.
Okay, great. So I know that you were able to answer some of the questions about specific subtypes, and others you don't know off the top of your head. But
yeah.
The chance was just wondering about CMT4C, which is the SH3TC2 mutation. I know Dr. Cleapo was working on a gene therapy approach a couple of years ago, and just didn't really hear anything today about it. So was wondering if you had anything to share.
Yeah, I do know that one. That's one of the more common recessive forms of CMT, but I don't know offhand what sort of the research is, the status is on that. But that would, in general, fall into the category. So that I don't know if. So we heard a little bit yesterday about efforts in another recessive form of CMT called FIG4, and there was some really impressive work showing basically gene therapy. So the recessive forms, as I said, are sort of usually, you don't have any copies of the disease gene, and so that particular gene product is lacking. And so these strategies to just put the gene back are likely to be really beneficial. And so while it wasn't that particular form of CMT, it was very similar in the mechanism. And so they were able to show that kind of replacing the lost gene was really, really beneficial. And if those kinds of strategies move forward and are shown to work, then it's only a matter of time before someone will be able to apply those same strategies to another recessive CMT like the one that you have.
Great, thanks so much. If anyone else on here has 4C, we do have like our own little Facebook group, so it would be great to connect with anyone else to try and build up our little patient community if there's any other 4Cers listening.
I think that's really a great thing to do for a lot of reasons, but as I've sort of mentioned, I work on this TRPV4 gene, and I've interacted with patient support groups from those families, and it's been a really nice back and forth where they help us learn more, and having groups of patients really helps researchers too, if they can get to the point of wanting to identify patients and do a natural history study or a clinical trial. Especially with rare forms, it's really helpful to have those have people already identified in a group, because it makes it much more straightforward to move sort of animal model studies to actual patients. So I encourage any of you out there, if you have the bandwidth to do so, to reach out and connect with each other.
Perfect. Well, Brett, thank you so much for this very informative session, and everyone here for all of your great questions. I think we are at time to rejoin the main session. It should be in the chat for everyone to click that link. Any last words, Brett, as people move back to the main session?
I just put in a plug to try to get connected with CMT specialists, and if you're in a place where you can get involved in some kind of natural history study, I think those are really important. And also, like I just said, connect with each other, which is, I think, helpful on a lot of levels.
Awesome. Great. Well, thank you, Brett. Thank you, everyone. We'll see you again soon.
Time flew.